Hi, this is Rich Branson, Editor-in-Chief of Respiratory Care. I'm a respiratory therapist and in the Department of Surgery at the University of Cincinnati. Joining me today is Dr. Brittany Burton, who's a third-year resident in anesthesia at UCLA, and Dr. Ulrich Schmidt, who is a professor of anesthesia at UCSD. Thanks for joining me today.
Thank you for having us.
Thank you very much.
Dr. Burton is the first author of a paper in Respiratory Care this month that's our featured paper called The Influence of Hospital Urbanicity on Mortality in Patients with Acute Respiratory Failure, a National Cohort Retrospective Analysis. So, Dr. Burton, I'm going to start asking you, what's the generation of your hypothesis for pursuing this paper?
The reason why we pursued this paper is because of the current environment in the United States. There are many racial issues, and there continues to be racial tension in this country. And I use the word race because race is tied to urbanicity. Urban areas were developed in ways to sort of segregate in certain racial groups. So in my opinion, race and urbanicity sort of go hand in hand. So given the current state of this country, we do think that it is important to consider race, to consider urbanicity in research as we move forward.
So let me ask you real quickly, and I hadn't thought about this before. Tell us just real quickly, where are you drawing this data from? It's a national database.
So the project is being drawn from a database called the National Inpatient Sample. It's with the Healthcare Cost and Utilization Project, and it's basically AHRQ data. It's publicly available data, so anyone who's tied to or affiliated with a healthcare organization has access to this data.
So one of the questions I get is, define for me urbanicity, or are there other words that we might be more familiar with when we're talking about urbanicity?
That's the way we define urbanicity, of course, is going to depend on the person. I think we all have our own personal experience with the word urbanicity, but the United States Census Bureau defines urbanicity as a metropolitan area with more than, I believe, 50,000 individuals. So in the strictest sense, that's how we can define urbanicity. But my personal experience with urbanicity has been geographic locations with a large percentage of either African Americans, Latinx, or other groups that have been marginalized in the U.S.
So to chime in, I think
Please, Uli, go ahead.
To chime in, I think unfortunately, the two definitions we just heard overlap. Because in the United States, historically, and for me as a foreigner, it's a little bit easier to see it from the outside. Poor people were drawn into the cities and segregated there, very differently from my European background, where rich people live in the city, and maybe New York City is the only city where it's different, where you have your $1 billion apartment. Every other city is poor people are in the city, and rich people live in the suburbs or live outside the city and just come in for work and food, and the poor people live there. And we see this very clearly in most cities in the United States.
So we talked a little bit before. I've worked in an urban hospital. My first day on the job was in August of 1979. And I think some people have talked to me about this paper and said, Rich, I work in the academic medical center. How can our outcomes be worse than the outcomes in these rural hospitals? We have an ECMO program, we have world authorities on critical care and mechanical ventilation and anesthesia. What causes this disparity in the outcomes because of urbanicity?
So I can give you an answer, and it might be a little bit temporary. I give you an example. When you bring a totally wrecked car to the best car dealer in the world to fix it, he will not make a Ferrari out of it. When you bring a brand new Ferrari to a mediocre dealer or a mediocre repair shop, they will repair it. And that's our problem. So this patient come late, they come sicker, they come with all these underlying diseases to us, and the best doctors with the best technology and the best respiratory therapists in the world will not get them to the same level when somebody gets paid 5 times a week to go to the gym and has a personal trainer. And I think that's unfortunately the underlying reason for this. I think, Brittany, do you have anything to add?
Oh, I definitely agree with that. And I think that I think the answer is in the question. And what we've basically just stated is that everything the hospital has ECMO. The hospital has world-renowned attendings. But the question is, what does the patient have? What does that community have? What is the trust between the patient and the medical community? Those are the questions that I think we really need to be answering. And that's sort of the foundation of this work, is to understand the patient population. Once you understand the patient population, then we have a better sense on how to address the issues in these communities. The focus needs to be off of the medical community because we know how to do our job. We know how to advance technology. But what I think we struggle with is integrating all that with a patient-centered approach. And we have to know our communities in order to do that.
So Brittany, without asking leading questions, so give us an idea. I mean, the first thing that comes to mind is you said it, and has been a problem with vaccines, is distrust,
Mm-hmm.
you know, in the medical community by patients in these areas. What about other things like being in food deserts and access to healthcare? What are some of those background causes of why these patients are sicker when they arrive?
Oh, I think it's definitely to Dr. Schmidt's point, and that when you're in a food desert, that's going to be associated with obesity, poor nutrition. Obesity, we know, is associated with diabetes and hypertension. You complicate that with older age, you complicate that with presenting later, and then it doesn't matter the technology that you have at hand at your hospital, these patients ultimately will have poor outcomes. So I think it's not too difficult to see. I think when we take a step back, we can, and we really start to look at the patient population, it becomes, in my opinion, more evident as to why these patients fare out worse.
I think the biggest, the clearest example comes in OB, where no prenatal care, because they don't have an OB where they go, these poor women, and they come in the last minutes, and to have a last minute delivery, and obviously often an emergency delivery, and they have never been seen in the last 9 months, whereas people in the more affluent communities come and go every week to their OB, and something is wrong. Oh my God, you need this and this labs. So they are better prepared to have their vitamins, and everything is done for them. And then it becomes like whatever they choose, and it will be a great outcome. And this poor people have no care before. They come without any care to us.
So I think that's an
the
important
outcome of the, and then the outcome of the birth outcomes are horrible.
Mm-hmm.
I think that's an important issue here. And Brittany, I'm glad to hear you say that. This is the first time I've heard it placed like that, that the emphasis has to be shifted away from what we can do and what is it that happened to these people and in these areas, which clearly is partly due to racism over the years, over the way housing was handled,
Mm-hmm.
and all the issues that place people of color frequently, but also other people just of little means in a disadvantage when they come to the hospital. So I want to wind up so we don't go too long. Brittany, if you don't mind, can you give us your take-home message for your work?
I think the take-home message here is that patient populations in rural areas versus urban areas are very different. And because of that, the outcomes are different. But what we do notice is that urban hospitals, whether it's a teaching hospital or a non-teaching hospital, when compared to rural hospitals, patients who are admitted to urban hospitals have significantly worse outcomes with respect to mortality and with respect to hospital length of stay. So I think as we continue to develop our technology and we advance our interventions, we have to consider the patient population at hand. We have to understand and identify what those needs are, and we have to tailor our intervention to those needs. For example, in urban areas, is the issue technology or is the issue trust and community building? In rural areas, is the issue access to medical care, or is the issue something else that we need to think about? So the take-home message is consider your patient population as you advance technology, as you advance and employ intervention. And I think if we're very specific in understanding our community, then we can do much better than we've done before.
Yeah, I'm hesitant and we don't have time to talk about solutions, but would it be fair to say that in your mind, maybe the first step that those of us who work in academic medical centers need to take is to reach out to the community and build that trust?
Absolutely, without a doubt. And I think that there are many examples over time. We have Henrietta Lacks and the misuse of her cells. We have the Tuskegee experiments. We have the Federal Housing Administration and the examples as such to show how ethnic and racial groups have been treated in time. So I think in order to sort of help these different communities, we do need to find a way to not rebuild the trust. We need to find a way to build the trust that was probably never there.
Okay. Again, Dr. Burton, Dr. Schmidt, thank you very much for your time. Thank you for choosing respiratory care. Uli, good to see you. I haven't seen you since you were still in Mass General.
Yep.
And we appreciate your time and sharing this information with the journal.
Thank you
Thank
so
you.
much. Thank you for having us.
Thank you.